Welcome, everyone. I'm very happy to see full house today. Today is a great pleasure to have with us Dr. Ramón García-Sanz. He's a friend of many of you and a colleague of the Institute and a long-standing figure in hematology in Spain. He trained as a hematologist at University Hospital in Salamanca. And he's the head of the molecular laboratory unit there, a researcher at the Cancer Center of Salamanca, and a associate professor in the university there. He studied, in fact, medicine in the same university, and his PhD work was about multiple myeloma. He did a postdoc training at the Erasmus University in Rotterdam, in the Netherlands. He's well known for his work in Hodgkin lymphoma, multiple myeloma, and particularly in Waldenström macroglobulinemia. He has published many papers. He's an active participant in Spanish groups like PETEMA, GELTAMO, and others. He's the coordinator now of the tumor hematology program of the CIBERONC network in Spain, and he was a former president of the Spanish Society of Hematology, like Evarist was a time ago. We're talking about this. His main contributions are in the area of Waldenström macroglobulinemia, flow cytometry, molecular methods, prognostic factors, and now to study the clonal evolution of the disease. And I think that will be the subject of his talk. Thank you very much.
Thank you, Manel. Thank you for inviting me to be here today. It's an honor and a privilege to share with you some thoughts about hematology. I always put this slide in since 1 year and a half ago, because it's a new hospital, and we are very proud about it. And my talk is going to focus on the impact of molecular characterization in hematological malignancies, but this is a very wide topic, so I'm going to use Waldenström's macroglobulinemia as an example of how these new possibilities have impacted our daily practice. These are my disclosures. And this is a slide that I used almost 8 years ago in Santiago in the National Spanish Society meeting in the educational program, in order to show how this methodology, the sequencing, the high throughput sequencing, has impacted our daily practice, because we have had many new possibilities thanks to these new tools that have provided us many opportunities to evaluate our patients. In hematology, we have to divide, from the clinical point of view, we have to divide it in 2 types of applications for next generation sequencing. That are, one is to sequence a lot of DNA, but with low coverage, which is the whole genome sequencing and the whole exome sequencing that can provide us coverages of 100 to or 1,000 maybe. That is difficult for us to evaluate correctly, especially in tumors and especially in hematological tumors, when we are in front of patients of samples that sometimes have only a few cells of tumor cells within a lot of normal cells. So it's difficult to interpret it sometimes this new technology, especially in clinical practice. So we prefer the other one, which is to sequence less DNA, but with a high coverage. And we are using multiple targets, the typical panels that we are using already in daily practice, that provides us a coverage of 1,000, 10,000, maybe more. Or using single targets, in which we read the target a lot of times, million of reads per sample, and this is very useful in minimal residual disease in order to focus on a specific mutation that can be diluted into million normal cells in order to detect if it is present or not. With these technologies, we have had many new information that has obliged us to redefine many of our the disorders that we focused. And this is an example. We have a new lymphoid classification. We also have a new myeloid classification. This is the international consensus classification that has tried to incorporate in the daily practice all these possibilities. But maybe we have even too much information. This is the reason of why we have not only one classification, but two classifications. I prefer the other one, it's more clinical, but we also have this other classification, is the fifth classification of hematological tumors, lymphoid and myeloid at the same time. It's a pity for us because it's very difficult to manage with these two classifications. They are quite similar, but they have small differences in almost any disease. So it's difficult for us to study both classifications at the same time. Well, to show how this has impacted our daily practice in reality, I'm going to use this disorder, Waldenström's macroglobulinemia, that was defined almost 80 years ago in 1944 by this guy. He was Jan Waldenström, that gave the name to the disorder. And since his definition, we have improved a lot in the last years. In the last 40 years, we have improved from a disorder which is indolent. It had an outcome with a survival around 5 years, but now we are longer than 10 years, and we are probably more. And we are saying that this disorder, thanks to the advantage that we have had in diagnostics and in therapeutics, we can tell the patient that he's going to live the same years that another person with the same age and sex in the general population. This is something that really has impacted our patients. And what is Waldenström macroglobulinemia? For those who don't know what is this disorder, Waldenström is an uncommon lymphoproliferative disorder characterized by two things. One is the presence of bone marrow infiltration, and the other one is the presence of a monoclonal component, a monoclonal protein in the serum, which is an IgM type. And the underlying diagnosis behind in the bone marrow, what is infiltration in the bone marrow, is a lymphoplasmacytic lymphoma, and it was defined in the first WHO classifications, which is a mixture of cells that are heterogeneous with lymphocytes, lymphoplasmacytes, and plasma cells. It's a disorder in between chronic lymphocytic leukemia and multiple myeloma, with a mixture of all cells that we can find between them. And it's important to say this aspect, which is about 10%. Many pathologists are saying that we require more than 10% lymphocytes, lymphoplasmacytes, or plasma cells infiltrating the bone marrow, but this is not accepted by the international consensus classification that says that if you have aggregates of clonal cells, you will have Waldenström's macroglobulinemia independently if they are more or less than 10%. This is something different between the international consensus classification and the WHO classification, because in the WHO classification, the presence of the alter ego, the pre-tumoral status, which is the monoclonal gammopathy of uncertain significance, the MGUS, requires to have the IgM monoclonal component, but less than 10% bone marrow infiltration, which means that if you have more than 10, you have a Waldenström macroglobulinemia. So the 10% is still maintained for some pathologists. This is the cell that is the responsible of the disease. This cell, the lymphoplasmacyte, that is just in between a plasma cell and a lymphocyte. Although they are only part of the tumor, most of the tumor are lymphocytes. And this is the second requirement, the presence of a monoclonal component in the proteinogram that is of type, and that has to be an IgM type, which is recognized in the immunofixation. These two aspects, together with the presence or not of symptoms, divides the disorder in four types of monoclonal gammopathies of IgM that are symptomatic Waldenström macroglobulinemia. We have the two aspects, monoclonal protein and bone marrow infiltration, but also symptoms derived from the presence of the monoclonal component and or the presence of the bone marrow infiltration. This is in contrast of the asymptomatic cases in which you have both the monoclonal protein and the bone marrow infiltration, but there are no symptoms. And this disorder is not treated at this moment by nobody. It's the consensus at this moment. And finally, in the last, in the down part of the table, we have the MGAS, the monoclonal gammopathy of uncertain significance. We have only the monoclonal protein, but we don't see bone marrow infiltration, and we don't have symptoms derived from any of the two aspects of the disorder. There are still a small number of patients, very small, that are called patients with IgM-related disorders. We have the monoclonal component. We don't have the bone marrow infiltration or any other tissue infiltrated by the tumor cells. But so we don't have symptoms due to the tumor infiltration, but we have symptoms due to the monoclonal component. We can have problems in the coagulation, we can have problems with peripheral neuropathy, problems in the skin, amyloidosis, etc. These patients are called patients who have IgM monoclonal related disorder. So this is something that is necessary for distinguishing all these four groups. Bone biopsy is mandatory in all these patients, which is something that we appreciate a lot in the laboratory because we will have samples from these patients. The patient has to be evaluated with several aspects that I am not going into detail, with the exception of bone marrow aspiration and biopsy that will be the source of the tumor cells that we can analyze in all these patients. And we will analyze them with three specific methods. One is flow cytometry. Flow cytometry is crucial for the diagnosis of these patients. We will see lymphoid cells with typical PAN-B markers. I'm sorry for the Spanish in the slide. PAN-B markers that are immunoglobulin surface with kappa or line chain restriction. And we also can see CD19, CD20 as PAN-B markers, and some other markers, for instance, CD22 or CD25, that are very specific, because with these two markers we can select many patients that have this specific phenotype is CD25 homogeneous expression and CD20 weak expression, which is very different from other normal cells or tumor cells. As you can see here, these are cells that we can find in the normal population and also in patients with marginal zone lymphoma, a lymphoma that is quite similar to the lymphoplasmacytic lymphoma that infiltrates the bone marrow in these patients. And with this approach, we can start to design precision medicine in these patients. One is with the CD20, because CD20 is expressed along all the B-cell lymphoid differentiation, and specifically in Waldenström macroglobulinemia cells, it is highly expressed. So we can use CD20 as a marker in this, as a treatment in these patients. This was the results of the treatment in the past, when in the era before CD20, before CD20 was available, and we were not bad, but we were not especially happy. 60% global responses, almost never complete responses, And our patients' life were living just 10 years, and without disorder, less than 30% at 5 years of therapy. So not bad, but not so good. We wanted to improve these results. And when anti-CD20 appeared in lymphomas, for instance, these are data for diffuse large B-cell lymphoma, in which clearly patients benefit of the use of rituximab, we started to use also rituximab in Waldenström's macroglobulinemia patient. In the early 2000s, it was very difficult to do randomized studies. There were no randomized studies to demonstrate that CD20 was better for our patients. But we can see that there are responses only with rituximab in Waldenström's macroglobulinemia patients, and at least half of the patients responded to the therapy. Although we can see that the response were not very long, around 2 years or less than 2 years of duration, but only with rituximab we were able to see that our patients could live for a long time, for some long time. However, it is not enough, obviously, and this was one of the reasons of why the patients, we decided that rituximab alone was not good for our patients, and this phenomenon, the flare phenomenon, is another reason of why we don't use rituximab alone, because this is a paradoxical effect in which the monoclonal component is increased during the first 1 or 2 months after therapy, something that is not very good for our patients, because we can worsen the symptoms of the patients because of the increase of the monoclonal component, and because it's very difficult to evaluate the response in these patients when we have an increase in the monoclonal component. So we prefer at this moment to combine rituximab with different therapies. One of the most typical associations is the use of bendamustine, in which we can see now very good responses. Almost all patients respond to the therapy, 96% of the patients, and with responses that can have a length of more than 6 years of response. So this is something that has changed a lot the life of the patients. It's interesting that it is not always the same in Waldenström as in other lymphomas. For instance, this is the response or the duration of the response that we can observe in follicular lymphomas with rituximab as maintenance therapy, and a clear improvement in the progression-free survival, but this is not the same for Waldenström's macroglobulinemia. CD20 therapy in these patients do not provide an improvement in the response, in the duration of response of the patients. So we are not using CD20 as maintenance therapy. And with the new tools in flow cytometry, all the data that I have provided you were obtained with 3-color flow cytometry. We have now 8 colors cytometry. In our laboratory, we have a 12-color flow cytometer. I know that there are flow cytometers with 45 colors, so it's and the MALDI-TOF also can provide more specificities. So it's very important that to say that we can see the phenotype of the Waldenström cells with very specific description of the antigens. For instance, and it's having an impact on the new therapies. For instance, we know that anti-BCMA antibodies or CAR T cells with BCMA cannot be used in Waldenström macroglobulinemia because these cells do not express BCMA. Or CD22, you show that CD22 is weak, so it's not a good antibody for treating Waldenström cells in the future with CAR Ts or with BiTEs, but we can use CD19, CD20, etc. Some other therapies based on these aspects of the precision medicine. The second technique that we are going to use to evaluate our patients with Waldenström macroglobulinemia is cytogenetics. Cytogenetics was used a lot in the past in order to try to discover a common abnormality in Waldenström macroglobulinemia. We wanted to have this similar thing as we had in chronic myeloid leukemia, but that was impossible. There are no specific cytogenetic changes in patients with this disease, although there are some abnormalities that are common. For instance, deletion 6q is present in around 1/3 of Waldenström's macroglobulinemia patients. But, and this can be detected by FISH studies, but it's very important to do it in samples with CD19 enrichment, because in the left you can see that the usual situation with the bone marrow of these patients, after diluting the bone marrow during the aspiration, we can have usually 5 to 10% tumor cells that are confounded with the normal cells. So in the right, you can see the use of CD19 enrichment. 85% of the cells are now B cells that will provide us a much better definition of the disease. More than enough for FISH studies in order to discover the presence of the 6q deletion. At this moment in our laboratory, we are using a new methodology, which is an indirect CD19 selection. We are excluding cells in the samples that are CD3 positive, CD40 positive, or CD56 positive, apart from the elimination of the myeloid cells during the fecal pack centrifugation. And these are the results after the selection. You can see that 99.83% of the cells are B cells. So a very pure population, which can provide us very good results for these patients. And with this methodology, we can detect this deletion 6q that is very important for our patients. In the right, you can see that it's a prognostic factor for symptomatic patients that do worse, a little worse than patients without the 6q deletion. But it's more important to say that in patients with the asymptomatic disorder, the asymptomatic Waldenström's macroglobulinemia, will have a much shorter period free of therapy than the patient if they have deletion 6q than when they don't have deletion 6q. So it's at this moment a current recommendation of the European Consortium in Waldenström's macroglobulinemia to do the 6q diagnosis in all patients with asymptomatic Waldenström's macroglobulinemia. And that was the situation until these new techniques arrived to the hematology, especially because of this work that was presented in the ASH of 2011, in which the first genome analysis, whole genome analysis, was done in this patient, and that led to the discovery of the MYD88 mutation that was published in New England Journal of Medicine. In that paper, they evaluated 10 Waldenström macroglobulinemia patients with by whole genome sequencing in both normal and abnormal cells, and in 20 patients in which they are evaluated only the abnormal cells. And all the results were validated by Sanger sequencing, and this was the main results. We can discover here the presence of this loss of the chromosome 6q, some gains, some other losses, but the most important were the point mutations that were discovered in these patients. Here you can see that 87% of the patients have this unique mutation that is present in the MYD88 gene. Presumed myeloid gene in the past, not anymore since that point, because it has this mutation, substitution of alleucine with a proline in the 265 amino acid that leads to an increase in the function of the mediated, a gain of function in the mediated gene, which is the responsible of an increase in the pathways of the BTK, of the BCR pathway and the toll-like receptor pathway. This mutation was very quickly confirmed by many other groups. For instance, our group, these are the first results of the Spanish group, in which we were able to see the presence of the mutation in also in 86% of the patients, including MGUS patients, and this was never present in myeloma. In that moment, it was not present in any of our BCLL patients, although we know that BCLL is positive now in around 2% of the patients, but it also was never present in MGUS of AGM or AGI or in healthy volunteers. And if we use more sensitive techniques, for instance, droplet digital PCR in the bone marrow, we can reach a 94% patients with the mutation. And even more, there are some other patients, around 3–4% of the patients that can have mutations in the mediated gene, but outside the L265 point. So virtually all patients with Waldenström macroglobulinemia can have this mutation. I think that it's also present in all IgM MGUS, but we need, in this case, we have much less number of tumor cells. So at this moment, we can detect only in around 80% of the patients with MGUS. Other mutated genes there were not many, but much less than in other disorders. And the other important gene is this one, the CXCR4 gene, that is an engager of the cells to the bone marrow. And it is present in around in our series of 76 patients that were evaluated by Sanger sequencing. We detected 34% of the patients. In the Boston group, they usually say that they reach 40% of the patients. It is dependent on the sensitivity of the technique. We have to use CD19 selection, and after that, Sanger in that moment, or now with NGS, we can get this 40% of patients with this mutation. But there are this is not a single point mutation. There are several points in the gene that can be affected. What is important is that, again, this mutation, despite it produces stop codons or frame shift mutations, despite this, it results in a gain on the function of the CXCR4. Some other mutations are less frequent, as less than 10% are not very well known yet. Although P53 is present in around 5% of 6% of the patients at diagnosis and provides a poor prognosis. It's not, these other mutations are not very frequent in this disorder. What is important is that in this series that we evaluated with a panel of 20 genes, despite the small number of genes that were used, we can see that MGUS have less percentage of mutations than asymptomatic Waldenström macroglobulinemia, and this less than the Waldenström macroglobulinemia, from 22 to 50% of the patients. So there is a clear association between the clone aggressiveness and the number of mutations, being more and more complex, associated with a worse prognosis. And another important thing is that we evaluated 76 patients, but 6 of them were negative for mediated, but only mediated were present, these mutations were present in patients with the mediated mutation. So it is clear that mediated is the founder mutation in these patients that gain more and more mutations with the evolution, and that patients without the mediated mutation are probably a different subset of patients. Many people are saying that they are not really Waldenström's macroglobulinemia patients, especially because they have a different behavior. These patients without this mutation, those who are mediated wild type are in the blue line and have a poorer prognosis with chemoimmunotherapy, and we will see that they will have a lower response to the specific therapy that we are using in these patients, because I said that these patients have the possibility of being treated with precision therapy, including the use of BTK inhibitors that are blocking this pathway, the toll-like receptor pathway. If we block here the BTK, the Bruton tyrosine kinase pathway, and also the BCR pathway can also be stopped with these drugs. And this is the reason of why BTK inhibitors are so efficient in patients with Waldenström's macroglobulinemia. These treatments were started to be evaluated in this trial that was published in 2015, in which the use of ibrutinib, the first-in-class BTK inhibitor, has a very good responses, 87% responses in patients who were in second-line therapy or beyond. So, and the responses are very, very, very long. These results were confirmed by other groups. This is another trial with quite similar results and very good survivals for the patients. And also in real life, when this drug were approved in the past, and everybody started to use them, you can see that patients in the red curve have a much better, treated with BTK inhibitors, have a much better survival than patients who were treated with prior therapies in the past. And it's very interesting because the response of to these drugs are highly dependent on the presence or not of the mediated mutation. Here you can see the reduction of the IgM monoclonal component by using these drugs in patients who are mediated positives and who lack on the CXCR4 mutation. Here you can see the response in patients who are the first group was mediated positive, CXCR4 negative. The second group has the two mutations, and the last group is that the one that has only that has the mediated in wild type. So a clear relation with the mutations that are present in these patients. Not only with the reduction of the monoclonal component, but also with the increase in the hemoglobin level. That are the two main characteristics that we evaluate in the response. Even more, in the seminal trial, there were 7 patients who were theoretically mediated negative, but they lack on the L265P mutation. But later, the Boston group evaluated these 7 patients who had no mediated mutations and sequenced the complete mediated gene, not only the 265 point. And when they evaluated the complete gene, they saw that there were 2 patients who had a mutation in another place different to the 265 point. And these 2 patients were responsive to the therapy. So at the end of the day, these 5 patients who lack on the mediated mutation, none of them had a major response, and only minor responses could be seen in 60% of the patients. So a clear relationship with the mutation and the response to these drugs. It's interesting that this resistance or theoretical resistance to ibrutinib by mediated cells can be overcome with the use of the association of rituximab. When we evaluate patients with rituximab, some major responses can be seen despite the lack of the mutation. And this has also been evaluated with the second generation BTK inhibitors that are zanubrutinib and acalabrutinib. They are different to the ibrutinib, because ibrutinib has many, apart from the for targeting the Bruton tyrosine kinase, ibrutinib can target other kinases, providing off-target effects that are responsible of secondary effects. The new drugs, acalabrutinib or zanubrutinib, were much more specific and could be used with a higher doses. So it was feasible to have a different effect on these patients, and it was demonstrated in this trial. That is the first trial in Waldenström's macroglobulinemia comparing two drugs in a head-to-head comparison. So 75 patients, 100 patients treated with ibrutinib, 100 patients treated with zanubrutinib. And of course, we were able to see the less toxic effects with zanubrutinib, similar overall global responses for the global population, but in patients who were negative for MYD88, we can see responses with zanubrutinib, up to 70% major responses in these patients, which means that it's possible to overcome the resistance to ibrutinib by the MYD88 wild-type patients by using these new compounds. Another thing that we were able to see in this trial was this evaluation of more mutations. There are many other mutations that were evaluated in many patients. You can see that the percentage of mutations is very low, with the exception of some of them, for instance, TP53, that are much more frequent in these patients than than, as I said, in the first-line patients, 6%. Here, TP53 is present in 24% of the patients, because most of the patients included in this trial were patients in second line or beyond. And this has an impact on the response, especially when we evaluate patients treated with ibrutinib. The responses are 87% with in patients who didn't have TP53 mutations, but are much lower with in patients who had mutations in TP53. But this was overcome when we use zanubrutinib, 82% for patients with the mutation, without the mutations, and 81% in patients with TP53 mutations. So these mutations that are of poor prognosis for these patients can be overcome with the use of these new drugs. And some words for the other relevant mutation in terms of precision medicine. This is the CXCR4 protein that is present in the B cells. It has a tail that disappeared with the presence of the mutations that affect CXCR4. And the disappearance of this tail results in a low metabolization of the protein, so it results in a final increase of function, in a longer survival for this protein. And it is thought that this longer presence of CXCR4 in these cells is responsible of resistance to the drug due to the activation of AKT and ERK pathways. This has been seen in all trials in which we have used ibrutinib or such as this one. We can see that the responses are lower when this mutation is present, but this is not the same with zanubrutinib. Another point that explains that this drug could be more effective. So we have some new additions with the use of these drugs in these patients. We know that the use of the presence of CXCR4 is a poor prognosis in these patients, especially when they are frame shift mutations. And some groups have tried to overcome this mechanism of resistance to ibrutinib, for instance, using a specific antibody anti-CXCR4, which is ulucuplamab, and in combination with ibrutinib in patients with the mutations. There are only 11 patients in this trial, but it was enough to say that the response was 100% in all these patients with very good partial response, more than 90% reductions that are possible by using this combination, which is something that is very demonstrative of how to overcome the resistance in these patients. Unfortunately, the number of patients is so low that the company has decided not to progress with this drug, and we cannot gain any clinical practice advantage for our patients. However, we know that we have some table to get, that is the use of proteasome inhibitors, because we know that patients with CXCR4 mutations do exactly the same as patients without CXCR4 mutations with the use of combinations with proteasome inhibitors. That is the other possible use of drug that we have for these patients. So, just coming to the end, if you have followed all the possibilities that I have mentioned in these patients, we have many possibilities for using in these patients. And it's very difficult to decide which one is good or better for our patient. At this moment, we are using a clinical oriented strategy, that is the young and fit patients versus the older and fit patients. For these young patients, we prefer the use of proteasome inhibitors plus DEXA and rituximab, because we preserve the bone marrow for the hematopoietic stem cell. They are not toxic for these cells. If the patient is older, and we don't plan any transplant for these patients, patient with 65, 70 years of age, R-Benda is a possibility, because we are going to have virtually 100% of responses with a duration, the promise of duration of 6-7 years. If the patient is older, and has a poorer condition, CDR is very well tolerated. It promises 80% responses. It promises 3 or 4 years of duration. And if the patient is in a very poor condition, we can use the BTK inhibitor as the low toxic drug, oral drug, although with a indefinite with a never-ending stopping therapy, which is something that we hate. However, I have shown you at least 3 different types of Waldenströms: mediated without CXCR4, in the middle mediated with CXCR4 mutations, in the right mediated negative. And what we are trying to go is to a molecular-oriented therapy by using, in this first patients, zanubrutinib and ibrutinib. The responses are exceptionally good, and the toxicity is not very high. In the middle, proteasome inhibitors are the preference, maybe with the use of chemotherapy or zanubrutinib that are the promise in the second step. And for the patients who are mediated negative, chemoimmunotherapy is the best possibility now, although we could also think of the use of ibrutinib. And that's all. This is my group that works with me in the laboratory, in which we have evaluated many of the data of these patients. And if somebody wants anything, I am now able for questions. And I always finish my talks with the photography of Professor Jan Waldenström. Thank you very much for your attention.
Thank you very much, Ramón. So before giving time for the people here, 2 very short questions. One is, one relates to the, you can target the pathway by using PTK and BCR drugs. I understand that the protein itself
NYD88 cannot be target, or there are the mutated protein itself?
There is a trial ongoing, but the first, with a specific inhibitor of the mediatate, but the initial results are not good, are not very good. It works in cell lines in vitro, but when the company has tried to go for the patients, up to now, and my last news is that it's not working as well as other drugs. This is the problem at this moment in many disorders. If we have very good responses to the current therapy, it's very difficult to introduce anyone.
And the MYD88 mutation at the beginning, 65. When you go deep sequencing, you see 90% presence. I think you mentioned that.
Well, in the beginning, we were using a specific PCR with allele-specific PCR, and with that we found 86% as the Boston group, exactly the same. If you go with a higher, with a better sensitivity, with droplet digital PCR, you can get 95%. It is also dependent on the number of cells, because you know that when you pump out the bone marrow from the bone, it's very easy to dilute the cells within the peripheral blood. And the other point that we are using at this moment, although is done only by our group in collaboration with the Torino group, that we are using droplet digital PCR in circulating tumor DNA. At this moment, we are having almost the same sensitivity as the bone marrow, as the evaluation of bone marrow cells. A little bit lower, 94% versus 96%. But I think that it will be the future for the detection of it.
If we think about this percentage so high, so any clue if this mutation can be part of the clonal hematopoiesis landscape? So this can be one gene that is mutated in people, normal people, in a very small subset of cells.
Well, at this moment, it has not been found in healthy people. So a healthy person without monoclonal component has not been seen. There are some exceptions, chronic lymphocytic leukemia, but there is a tumor disorder. It's around, if I remember well, in the last evaluation, is 1.8% of the patients have the mutation. In some diffuse large B-cell lymphomas, that many people is thinking that they are transformations from prior lymphoplasmacytic lymphomas. And the other point, that this is something that was found in the Navarra group, in the CIMA, they found that there are normal cells within patients, but normal cells with normal immunophenotype that can harbor the mutation, and they could be the real founder cell of the clone. That could be at the beginning with a single mutation that is not able to produce the disorder by itself alone. So it's possible that this is the first specific cell found in the tumor clone, the global tumor clone.
Thank you. Questions?
Thank you, Ramon, for this nice presentation. Is plerixafor used in cases of mutated CXCR4? Because it's the most inhibitor used, and we use regularly in clinical. Why is not available any trial using plerixafor?
No, it's not. It has not been used. I have made this question many times in all the groups in which we work, but nobody wants to use it. And first, because it produces a lot of leukocytosis. This is something that sometimes people don't want to see. While ulucupilumab, this other monoclonal antibody, did not produce this leukocytosis. But the real reason of why nobody has used plerixafor is not known. Maybe commercial reasons, or I don't know.
Okay, thank you.
Hi, yeah, thank you for your talk. I'm Ollie from Marcus's lab, but I had a question about your panel of genes that you found mutated. And in them you have various H1 histone linker proteins. And I was wondering if you'd ever looked into the prognostic value of these mutations, and also if within your sequencing experiment to find these mutations, whether perhaps the fact that there are so many copies of these genes that you would miss a lot of the mutations.
Well, the first question about the prognostic value is not, we don't have enough data to produce a specific prognostic classification of these patients using molecular data, just because we have only univariate data. It's very difficult to produce with multivariate data, so there are other aspects that are, other characteristics of the disorder that are better for the prognostic classification of the patients. The hemoglobin, albumin, size of the molecular component, etc. And the other point is that we are at this moment comfortable, I would say, with the use of these molecular alterations just for orienting the therapy. And the other question?
Was about, since H1s have so many copies in the genome that potentially through whole genome screening you wouldn't potentially see the depth of the mutation, since maybe only one copy could be mutated.
But I cannot understand you very well.
Sorry, maybe I need to speak better into the microphone and stick it to my face more.
Which one? No, I cannot respond to this. I cannot answer to this question. It's too specific for me, I think.
Thank you very much.
Yeah. Well, I remember that was evaluated in 2016. I think this is that paper, and I remember that we had many problems to evaluate correctly this gene, and at the end of the day was the final consensus that we have in the group that some other groups have not seen this mutation, so it's difficult to correctly evaluate this gene.
Hi, Ramon. Congratulations for this very nice presentation. In line with the question from Josep Maria regarding the targeting of CXCR4, do you know whether some agents targeting not only the extracellular part of the receptor, but some agents able to target maybe the transmembrane domain have been used in this pathology?
No, the only drug that has correctly evaluated, not only at the in vitro studies, but also in patients, is this one, ulicoplumab, that is a monoclonal antibody that targets the rest of the CXCR4 moiety. It's not. There are no other tests done with this drug. We have to remember that Waldenström is not frequent, and only 40% of the patients is less patients. Actually, the only trial that has been done had only 11 patients. So.
Nice talk, thanks. So I am curious about the difference that you see in the response in the MYD88 TP53 mutated cells to ibrutinib versus anibrutinib. So could you comment on which could be the mechanism for such difference? Because
the mechanism is not known. The only point is that we know that TP53 provides many proliferative advantages in many disorders, and this is the only explanation. So the question is that zanubrutinib seems to be more potent in these patients, and when it has to target the proliferation activity of the cells, and this is the only explanation, just an addition or a rest of activities in the cells. The exact mechanism of action is not well known.
I was just wondering whether the off-target effect of ibrutinib would be preventing the therapeutic.
Well, off-targets at this moment have only been evaluated due to the problems that ibrutinib provides, because ibrutinib produces some adverse events that are thought to be because of the targeting other tyrosine kinase or other kinases. For instance, vascular endothelial growth factor, that is also a kinase. And this is the reason why it produces cardiopathies. It produces arrhythmias, especially atrial fibrillation. It produces hypertension, and it also produces alterations in the primary hemostasia. So it's something that has been evaluated only for these aspects, not for other for targeting other pathways in the tumor cell.
Thank you very much for your talk, Ramon. I was just curious, so there are signs of germinal center reaction-related somatic hypermutations in the patients, or?
Well, somatic hypermutation, are you referring to the immunoglobulin gene receptor?
Yeah, well, but it can be it is known, right, that through the germinal center reaction, you can have like off-target mutations in other genes that are not immunoglobulin genes. So I don't know, because this is supposed to be post-germinal center tumor, but it's IgM still, so I am not sure if...
It is difficult to know, because it is thought that this is a post-germinal center cell, because it is heavily mutated in the immunoglobulin genes, which is the thing that happens in the germinal center reaction. But the problem is that mediated mutation has been shown in cells that are normal, but are very early in the B-cell differentiation. And I think that it's not yet completely demonstrated, but it is a thing that these cells are already mutated. They already have the immunoglobulin gene rearrangement completed. So this cell, although could be thought to be a post-germinal center cell, it has a very immature immunophenotype, CD34 positive, for instance. So it's difficult to puzzle all these possibilities.
And you said, if I am correct, that like the patients that showed more mutations had also worse prognosis. Am I correct?
This is the typical. We think that this is due to clonal evolution. So, due to the evolution of the clone, the cell is accumulating more and more mutations, and at the end of the day, actually, it also reacts. The cell also reacts in most patients as it happens in follicular lymphoma or CLL. It explodes with a diffuse large B-cell lymphoma.
But I guess that nobody has checked whether these mutations have like hallmarks of activation induced in the amylase activity, or like if it's in hotspots of AID or something like that.
No,
this is not known.
How they work in the amylase activity is not yet evaluated.
Okay.
No.
Okay, thank you very much.
Yeah. Is there any experience with venetoclax or in the combination with ibrutinib and venetoclax as occurs in CLL?
Yes. There are some trials that have evaluated venetoclax specifically in patients who were refractory to ibrutinib, and some of them were ibrutinib naive, and the responses are good, are better in patients who have not been treated with ibrutinib previously, but they respond. So it's another possibility of treating patients with venetoclax. The combination with venetoclax and ibrutinib has also been tested, as in chronic lymphocytic leukemia. It seems to be the future conventional therapy for chronic lymphocytic leukemia. But in Waldenström macroglobulinemia, it was a presentation in the last ASH meeting, in which they treated 26 patients, but they have had 3 major arrhythmias, ventricular arrhythmias with 2 sudden deaths, 1 almost sudden death that was recovered, and 1 ventricular arrhythmia during a exercise test. So 4 main arrhythmias in 26 patients. They stopped the trial and is at this moment blocked. Last question?
Sí, nice talk, Ramon. Thank you. What do you think about the value of the liquid biopsy in this kind of patients, not only as complement of the lymph node biopsy or bone marrow biopsy, also for following the action of the treatment, of the different treatment in these patients?
Well, I think that it's going to be part of the future. Actually, at this moment, it's very useful. For instance, you know that Waldenström macroglobulinemia is very rare. It's present, the diagnosis in Spain would be around 150 patients per year. So it's 4 patients per million in year. So it's not very frequent. But MGAS is very frequent. At this moment, the last results of the Iceland group was 5% of the people older than 50 have an MGAS, and 1/4 of them are of IgM type. So it's going to have a sanitary problem, I would say. It's to identify so many patients. So it's possible to see many patients with IgM MGAS. When to go for a bone marrow biopsy or bone marrow aspiration in so many people is very difficult. So liquid biopsy will have the opportunity to diagnose the presence of the mediated mutations, for instance, in all these patients before doing anything in the bone marrow. This is one. And the topic about MRD studies or following the treatment could be an option, but will not be very, very crucial because it is not sensitive enough. The sensitivity at this moment is 1 in 10,000, 1 in 100,000 maybe. You know that people is asking at this moment 10 to the minus 6, for instance, in myeloma. And in liquid biopsy, we have still less sensitivity. And the other point is that when you go for high sensitivities, you can find normal cells or immunophenotypically normal cells that have the mutation. So you can, maybe you are distinguishing a dormant cell that has no impact on the therapy for this patient.
Thank you.
Let's close it here. Let's thank the speaker again.
Okay.